If I could have everybody's attention. Hi. Good afternoon and welcome to this Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today. I'd like to welcome our web viewers and Ontario Telehealth Network sites. A special welcome to the members of our new University of Waterloo Health Informatics Club, UWIC. I see a number of students out there. Just to let you know, this is the first health informatics club of its nature in Canada. So I hope that perhaps I could just ask the members of the club to stand. Some are standing already. So if you wouldn't mind standing, a few people here. And we'd ask everyone to stay at the end of the seminar to meet the club members and over refreshments. So I welcome everybody to have some cookies and some refreshments which are at the back. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a microphone to you. For our virtual viewers, please send in your questions and we will ask them for you. These seminars are hosted by the Waterloo Institute for Health Informatics Research, the Lawson Health Research Institute, and the National Institutes for Health Informatics. We are very grateful to our seminar sponsors, McKesson Information Solutions, ITAC Health, and Healthcare Information Management and Communications Canada. We could not host these seminars without their support. Before we begin, I have several announcements, and I'll try to be quick about these. Our next Smarter Health Seminar will be on Tuesday, March 30th, and our speaker will be Mr. Bill Pascal, who is the Chief Technology Officer of the Canadian Medical Association. Our next Health Informatics Boot Camp will be held in this room from June 27th to the 29th, and registration will open for the boot camp in early February. Finally, I'm very pleased to announce the first Advances in Health Informatics Conference, which will be held at the University of Waterloo's Health Sciences campus in Kitchener, Ontario from April 28th to the 30th. This inaugural international conference will feature exciting keynote speakers and presentations from thought leaders, visionaries, researchers, and entrepreneurs from around the globe. It will be an innovative green conference in that participants can attend in person or via the web. So AHEC 2010 will include as well an interactive think tank on the current eHealth situation and strategies for going forward. Registration will begin in a few days. I hope that you will join us at this first global virtual health informatics conference to be held in Canada. So for more information, there's a flyer at the back, or you can contact me as well. Now, to why we are all here. We begin the year 2010 with a new theme, the eHealth crisis. We will look at this topic from many perspectives with the goal of understanding what the issues are and what we can do to solve this crisis, which is happening not just here but around the world. The schedule for today is as follows. Our speaker will talk for about 45 to 50 minutes, and at the conclusion of his presentation, we will have a facilitated discussion where you get to comment and ask your questions. So that we ask that you hold your questions to after the presentation, signal to us, and we'll get a mic to you. We invite our web and teleconference viewers to send in their questions as well. It is my pleasure to introduce our guest speaker, Mr. Doug Tessier. Doug is the Senior Vice President of Development and Implementation at eHealth Ontario. Doug joined eHealth Ontario in April 2009 after 26 years of service with the Ontario Ministry of Health and Long-Term Care. He holds a degree in mathematics and computer science from Queen's University. We won't hold that against him. As well as diplomas in business administration, and he is a certified information systems auditor. He has recently worked extensively with Queen's University Executive MBA program, facilitating high-performance teams, and as project advisor on global business projects related to healthcare and eHealth. Doug has been a champion of eHealth in Canada for over 15 years and deeply involved in health informatics for nearly 30 years. As the inaugural chair of Canada's Electronic Health Record Working Group, he has a unique insight into the development and implementation of eHealth and EHR in Canada. Many have recognized that the EHR is not the first priority, however. Our focus and target perhaps should be on the improvement of the health system. And it should be noted that eHealth in Ontario is doing just that by focusing on health system outcomes. The title of Doug's presentation is The Magical Vanishing EHR. So please welcome with me Mr. Doug Tessier.
Thank you, Shirley, and thanks to University of Waterloo and the research group for having me here today. This is a topic about which I get quite passionate, so I'll try to keep some control on that passion. And Shirley approached us, talked to my assistant, just before the holiday season. And I was not that familiar with this series, so I did a little research, watched a few of the presentations that were on the web, and I was really impressed with the topics and the depth and knowledge of the speakers, and of course as well the passion of the people who were here as well. And I think I had about 5 minutes to come up with a topic name and a little bit of an abstract, and I came up with the Magical Vanishing EHR, and I have to admit I sat in here in January thinking a little bit, why the heck did I pick that topic and how am I going to live up to that? But it's actually something that I've quite firmly believed for quite a while. The EHR is something that we hear a lot about, and probably the less we hear about it, the better. So the theme that you'll really see as I go through this is, let's get the EHR in place and forget about it. If it actually vanishes and we deliver lots of good healthcare services and get some outcomes from it, and eHealth and technology enables that, that's a good thing. But I might as well be right up front. The EHR is not the end goal. It's not actually a product. I consider it kind of a byproduct of some very good things that we're all going to do together. And a little bit of background about myself as well. Shirley, thank you very much for that glowing introduction. I'm from the boonies of Northern Ontario, a little town called Elk Lake, and I always describe to people, if you fly from Sudbury to Cochrane and you jump out halfway, you hit in this little town of 300 people. Why anyone would want to do that, I don't know. But it gives me a little bit of a perspective of what Ontario's like as you get a little bit farther from Highway 401. And I try to bring that to the work I've done with the Ministry of Health and that I'm now doing at eHealth Ontario. And a lot of the work I'm doing is the same line of business. It's a little bit different focus, and it's been a little bit different year, 2009 as well. And topics on that are fair game. Hopefully we won't focus on that entirely. The other thing is that when I was going through university at Queen's, I fought forest fires as my way to earn my income in the summer, and it was a good income. And if we don't get a little more snow this year, it's going to be a very good thing to work at next summer because we won't have much moisture in the forest. But it also teaches you that if you don't operate as a team, someone's going to get something burnt. And that is really one of the lessons that I've tried to apply all through my career. This is a team approach. The Ministry of Health or eHealth Ontario can't do this by itself. We need people from a clinical perspective, from the public and political advocates and lobbyists and the media all working on this together, because I actually think we've got a big problem. We're going to run out of money in our healthcare system soon. So I'm going to go through this, and after about 45 minutes I'll stop. And really I want to provide a little bit of insight on the creation, use, and issues around the EHR. And I want to spend a lot of time talking about the issues, because there are some challenges that all the technology in the world is not going to enable an EHR to help us transform the healthcare system. And I want to bring you up to date a little bit on some of the things that are going on at eHealth Ontario and progressing the strategy. And if you've been given the impression that everything that moves our strategy in eHealth in Ontario forward is at eHealth Ontario, I'm going to try to correct that impression as well, because that's not the case at all. There are some things that are focused there, but we've got to be working together. Partnership is a key element there. And then again, these issues. So I want to talk a little bit about the EHR first. And one of my big experiences on EHR over the years, I have to remember to keep my posture very good because I'm on camera. I tend to slouch and lean. One of the things I've discovered over the years, which I've found a little bit frustrating, and I was the inaugural chair of Canada's EHR working group. You go to a meeting and you appear to know something about something, and the next thing you know, you're a chair of a working group. But it had a really good group of thinkers around the table very knowledgeable, some from a clinical perspective, some from an E perspective. And one of the things that we did not spend a lot of time talking about was the definition of an EHR. And trust me, I can go nowadays and find people who will sit around for 6 or 7 hours to talk about the definition of an EHR, and I won't stay for 6 or 7 hours because I don't think it's the most important topic in the world. I really want to talk about what we're going to do with an EHR. Now, saying that, I start with my first slide on kind of the definition of an EHR. And there are lots of experts out there who will tell you what an EHR is. And this is, I think our definition is getting a lot better. It started out kind of when I was first involved with it, with Health Canada and some deadly researchers talking about longitudinal records, and there were so many adjectives in the definition of it that you would have a real hard time pinning it down. So I really like the fact that it's secure. And is it your electronic health record? If it's not secure, well, I guess it might still be. But it's a record of an individual's key health history. And as Shirley said, I spent a lot of time, or at least I have in the past spent a lot of time with the Queen's Executive MBA program. And it's always interesting dealing with executives because they think they know all the answers already. And one of the very first things they have to do is put together the mission statement for their team, because at Queen's it's a team-based program. And if you can't get along in a team environment, you can go and take your MBA somewhere else from an executive perspective. But one of the things we ask people to do is to define every word in their mission statement and make sure they're all on the same page. And one of the things I think about definitions of EHR, there are about 8 words in this sentence that require some definition. And if we need to do that, we need to understand them exactly the same way. Because people jump to solutions really quickly from an EHR perspective. So when it says it's secure, people assume that that means it's encrypted. It might mean that or not. It's certainly secure. And it's the same with private, lifetime, key health history. I think key is probably the most important word in there because I think people can define that 15 different ways quite easily and justify what they're doing as an EHR because it has the key information in it. You know, and if 2 people sitting beside each other in the room have different definitions, we've got a battle for who's actually got an EHR. And we're all trying to attract investors and politicians and key decision makers. And every time we have a battle, we hurt ourselves a little bit. So I think we need to get on the same page about what we're going to do about this. So the key, though, is it's made available electronically to authorized health providers. This comes out of InfoWay. And InfoWay, I think, has been a somewhat useful, I think a very useful vehicle in Canada in focusing things on eHealth. InfoWay's role is to accelerate electronic health record development, and I think they've done a good job in some areas of accelerating that, and certainly they're helping us with the definitions a little bit. But the thing in the statement in the green box is what I really like. It's being created to facilitate the sharing of key pieces of health information between multiple authorized custodians across the continuum of care. And that's really important because patients and people move across the continuum of care. So if I've got a really good job of information within a particular silo of the healthcare system, well, the person's going to move across that silo. And that's in reality, if someone asks me, what's the business problem we're trying to deal with, it's people moving across the continuum of care. And some of you will remember the old, what I used to call the right statement, the right information about the right person in the right place at the right time. You know, you kind of get tired of that after a while, but it doesn't make it wrong. And that's what we want to do. And I think, I'm not sure anyone watching on the webcast knows this, but I broke my wrist when I was in grade 6. I can tell you it was the day before I went on the school trip to Toronto, so I couldn't go in the swimming pool at this lovely school in Toronto that we visited. It was my right wrist, I remember, because I couldn't write, but I'm not sure. That's certainly part of my electronic health record. How relevant it is to very much of my care right now. So what I really want to make sure is that someone doesn't stop something because we're missing that piece of information. Let's get the right information for the situation and use it from a clinical perspective where it's appropriate. Do the right thing with the information that we have. And one of the things, the challenges in eHealth and electronic health records is it's a lot easier to stop something than it is to keep something going. And Newton would tell you that's not true, but I'm not a physicist. I'm not sure what you'd call me. I was a mathematician and mathematical modeler at one time, but I've been in government so long, I'm not sure you can apply that. But it is pretty easy to stop something because it's not a perfect solution. And it's interesting because one of my themes as we go through this is that Ontario is a fairly special place. Certainly from that aspect it is. I think there have been some other jurisdictions who've gone ahead with solutions that they knew weren't perfect, but they thought would move the yardsticks ahead. And I'm not sure if it's a timing issue or a funding issue or a political issue. We've had a tendency to wait in Ontario for the perfect solution and then advance the yardsticks. And I think we've actually been slow moving in some areas where we could have moved a long way. You'll see that theme as we go through. Everyone of my generation, I hope, I'm not sure my kids remember John F. Kennedy and the moon nearly as much as I do, but is the EHR our moon? And this was a question I like to pose because the moon did something very important. It focused the space program in the United States, and believe me, there's been all kinds of literature and research about whether that was the right thing to do and should they have bothered to go to the moon and was it worth the investment. But the message that I make around the EHR is that when John F. Kennedy talked about the moon, a lot of people know that one quote, but they have never read the full speech. And there were some important things he mentioned. So if we get to the moon and we don't have appropriate lunar spacecraft, I think we've got a problem for the three guys up there. And we need to do these other things along with it. We need to get the rocket fuel and the rocket engines. We need to push on with unmanned exploration. And clearly there's lots of analysis around this, but we need to do a lot better job on our weather observation. It's kind of important if you're going in and out of the atmosphere in various places and you want to land. We also have to get the satellite game a lot more prominent than it was. And this was 1960. And one of the challenges that I've certainly experienced a lot over the years is that people will say, I just want the EHR. And you go to them, okay, here are the 6 elements of that we need. And a perfect example of that is a client registration system. Just about everyone I talk to understands that in an EHR construct and around electronic health information, if I don't know who I'm dealing with and whose information this is, and I can't guarantee that, well, then I've got a problem. And, any emergency room physician or nurse will tell you if I'm not sure this information goes with this client, I go back to the start and I ignore everything I've got here. Well, one of the things Kennedy did was make sure that we've got the emphasis on at least some of these strategic elements that go with it. And that's one of the things we really have to look at from an EHR perspective. You don't go to Future Shop and buy an EHR system off the wall and install it and have everybody use the same one. I think we know that. We're a fairly intelligent audience. We've got a lot of systems in place now. We've got to actually think about the other things that we need to go along with this. And Kennedy made 2 statements that I think I've said to myself very many times over the electronic health record world. So if we're only going to go halfway, or when the going gets rough, we're not going to persevere, well, then let's forget it. And, I think sometimes I feel like I've got that attitude, but we persevere anyway. And the other thing he said is, let's decide right now. Do we want to be in this game? And if we do, then let's all commit to it collectively and work towards a goal of the moon landing in that case. But that was just the output of a space program, really. And maybe it's because I've worked in this eHealth game for a long time, we're already in it. We've already made the decision that we want it. So it is really important now, when times are tough, and the eHealth swirl and scandal has made it tough, the economy made it tough enough without any of that happening. But if we're in this game and we really believe that it can transform the healthcare system, or at least enable that transformation, then let's stick to it. And the other question around this is kind of the magical theme. Is the EHR our Nessie, or we are in Canada, so Ogopogo is well out in Okanagan Lake. This is not Nessie. This is what happens when you combine a warm, windy winter day and the lakeshore of Kingston, Ontario, with a drop to minus 25 the next morning. Everything freezes. You get ice all over everything. This is a pier in the west end of Kingston in Elevator Bay. But I've had lots of people say to me, we could really market this as a monster in Lake Ontario and get lots of attention for us. So we don't necessarily have to understand exactly what it is to get value from it, or at least that's one of my premises. An electronic health record, it may be an important concept, but we get lots of value out of concepts that we don't necessarily understand. And the perception of the value we're getting is often as important as the reality. And certainly from a political leverage and an investment perspective, that can be true, but it's got to actually be backed up. one of the things I like about this picture and the famous pictures of the Loch Ness Monster is you never see all the monster at the same time. And it's a little bit like that with the EHR in my concept of it. You may only expose part of it, and you may get tremendous value out of it. If all I do is look at someone's drug history and use a drug interaction tool, I haven't really pulled the full EHR into use, but I've got tremendous value. And marketing, I will tell you, and I think I'll get to it eventually, marketing is really important around an EHR because political decision makers and financial decision makers have latched onto the EHR concept. So we're, for better or worse, going to move forward towards an EHR, whether it's really where we're going or a byproduct of that, I think we're going to determine as we go forward. But we are going to have to use some of this exactly like a good tourism marketing bureau would use a picture like this. We're going to attract support and we're going to build momentum. But then we're going to have to figure out what we do with that. So we're going to have to figure out what were we really trying to achieve and learn from our successes and our failures. And by the way, one of the interesting things as well is there aren't only successes and failures. And we get very competitive from an EHR perspective, and we point to various projects, and not just from EHR, from eHealth and many perspectives. And in order for my project to be a success, someone else's probably has to be a failure. We're going to compare them, we're going to do relative things. I really think we need to get away from that paradigm as well. There's an awful lot of room between successes and failures. And we actually need to do some things with different approaches. Ontario, I can guarantee, as I said earlier, has spent a lot of time in that paralysis analysis mode, figuring out what's exactly the right solution. And sometimes you have to take some steps. You try it this way, I'll try it this way. We've got some basic concepts that we can agree upon, and we'll evaluate the results. While we were talking earlier today, some very interesting conversations and very passionate as well. We're not doing a good enough job of evaluating the results. And I think that's, there are probably islands and isolated incidents where people are doing a really good job, but I really think we need to pull more academics, more of the research community in place to actually figure out what we were trying to achieve, what the result was, and as well, what that result was linked to. Because the health system, pretty complicated. I can make a change over here and implement an e-tool, and there might be a change in the system, but I don't necessarily want to make that link and say that I've concluded it was caused by that. And let's face it, we're trying to transform the whole health system. I'm not sure a small tool in one place is going to do that. The other important thing, though, is that the electronic health record and many, many applications, I already talked about this a little bit, it is about the spaces in between. We're in Waterloo, Grand River Hospital is not far from here, a wonderful hospital information system. I think they're thinking about getting a new one or potentially having some linkages to other hospitals. It happens all the time. We have all the health information, I don't want to say all the health information you ever want, very large repositories in various organizations and in various systems. The EHR doesn't have very much to do with building those large repositories because a lot of them are already in place. The EHR has a lot to do with hooking those repositories together so that when you go from Grand River Hospital to your primary care doctor to whatever, you happen to be in an emergency room in Kingston while you're taking your child to Queens for their first year, if you make that excellent choice, you've got some access to that information, and it's about the spaces in between. And I will tell you as well, having been to places like Treasury Board, it's always an interesting place to go. It's not the most pleasant experience. There are some fairly arbitrary decisions made. And if you go and you've got a fairly large investment bucket for eHealth, and we're not exactly sure how that's all going to be spent over 10 years either, you've got a lot of money in integration. How do we take the information? How do we put it together? And a lot of that is around standards, and it's around messaging, and it's around common conventions, and business processes. The first thing that happens is they say, well, let's take this integration money out of here. It's not a clinical domain that I understand. I'll keep the DI funding and the drug funding and the lab funding and the physician funding, but I'm taking all the integration money out. That's the easiest thing to take out first. Well, you've sacrificed the EHR. I've made that statement. I don't work in government anymore, although I work fairly close to it, but it's something that we really need to get across. It is about the spaces in between, and then there's some important questions on here as well. It is multiple sources of information, but do we plan for normal volume or peak capacity? And that's one of those big issues. If you're dealing with wait times, If you had all the money in the world and you could put an MRI machine in every Max Milk or 7-Eleven, it really could shorten the wait list for MRIs. Well, they'd sit there unused most of the time. And by the way, one of the themes that came out is we need to start thinking a lot more about the appropriateness of who should have some of those tests, because that's a big factor that I think has been downplayed a little bit. Scalability and system performance. I'm trying to think of a really good example without naming names, but I don't know how many times as an IT and kind of an MIS healthcare guy over the years, someone's come up with a wonderful system. And every time there's a new database tool, this happens. Microsoft Access was one of those. And somebody, I can't remember his name, but was in one of the departments of the Ministry of Health, put together a really good provider system using an Access database. They had 200 providers in the system. It was the slickest thing you ever saw in your life. And it couldn't handle more than 1,000. As soon as you got to 1,000, the system just went right in the toilet or whatever you want to say. We're talking about massive systems. And it doesn't mean they all have to be massive centrally. But when you add up all the pieces, there's often very distributed systems that are massive as a whole. And we're going to churn some transactions through there that are pretty high volumes. And one thing I know from experience that you don't want to do is find out about a volume issue in live production. Trust me, the banks and those places, we'll talk about the financial industry a little bit more, but they do high volume testing long before something gets to production. And we still have nothing against, the Temiskaming Shores Hospital, if they call it that anymore. It was New Liskeard Hospital when I used to live there. If they built a great little system and the Northeast LHIN says we're going to use this as a LHIN solution, before they get very far down that path, they have to figure out if the technology is scalable, if the business processes are scalable. That's a big EHR thing that we don't have a lot of expertise in. And it costs money. If you're going to put together a system lab, maybe we'll put it at some university that does innovative things in IT. I'll have to think of which one I could come up with. That's the kind of thing we need to do. We've got to do volume testing in an environment on some of those things. I think there's a big business opportunity for someone to come along or for an academic institution to partner with someone to say, we'll help you with that problem. It's going to be a big deal in the future. One size doesn't fit all, and I like to vent a little bit in these presentations because I do a lot of them. I can't count the number of times over the years when someone in the minister's office or the premier's office or cabinet office has met someone at a cocktail party, and all very well intentioned and people who really care about this, but someone has said to them, I've got the answer to your eHealth problem. I took 2 weeks off last summer. I sat in my basement with my Mac. It's always a Mac. I don't know why. With my Mac, and I've got the system that will handle EHR in the province of Ontario, and for $1 million, I'll give it to you for the whole province. And it's usually higher than $1 million. Okay, my life would have been much calmer if I could have got those people to say, that's really not a viable solution. It is about the spaces in between. It's about the big infrastructure. There's a little bit of a big iron component for the technology guys. That doesn't mean there's not a place for those solutions, because there's some really innovative stuff came out of someone's basement on a weekend. We need to figure out where it fits in, but it's a question of context. It's not, let's use this as a solution for the whole province. Just let's see where this might fit in and be something really innovative that we can use locally. And then, as I've said before, you want to build a large repository and centralize it, knock yourself out. It's one of the easier things to do. It doesn't mean it's not expensive and there aren't scale issues, but that's not what the EHR is about, and I don't think it's what eHealth information is about either. This is one of my other things. This is really turning into a venting session. It's very good. I'm saving myself counseling fees. Why can't the EHR system in Ontario just work like our integrated financial system? I've been asked that. I can't possibly even figure out how many times. And I would describe it's not the fairest question in the world, but I try to come up with some answers where I can just make the noise go away. So this is my answer to this question. I talked to some of my friends, different people in different places around the province. This is the profile of the average income mid-career Ontario resident. You can read it yourself, but they've got multiple bank accounts in different institutions. Their pension plan's not connected. They saw an ad for ING Direct Savings, and they said, I'm going to get a savings account there. They've done a tax-free savings account, and they decided, well, I'm going to do it at this bank instead of mine. They've got a Bay card, a Sears card, an Esso card. They get paper bills on all those things. There's nothing integrated at all. They do e-file their taxes probably, though. And Some of them will actually do it on paper and then e-file it through a service. Lots of people use a software package. But the only thing that's fully integrated from our perspective is cash withdrawal at the point of service. And that is done really, really well. But it's not an integrated financial information system. So we've got to actually make some valid comparisons, because people are asking us to develop a fully integrated EHR and eHealth system and saying the banks can do it. Can't you guys do it? Well, maybe we'll work on a problem the size of cash withdrawal at the point of service. And that's where I think the EHR can really help us, and we'll move more towards an integrated system. And if there are people who really want to tell me later that the financial system's integrated more than that, we can have that discussion over a beverage at some point. But it's really important that we make valid comparisons. And we really need to take lessons from world leaders and figure out who those world leaders are, not only in what they do from an EHR perspective, but also in EHR marketing. And again, I'm being a little bit facetious on this, but we really need to understand what we're dealing with. So, Mexico, Andalusia, Great Britain, Australia, New Zealand, interesting environments and ecosystems, different motivations in their eHealth development for sure, but we really want to make sure that we look at models and learn from them, but let's not take a model that's very different than ours and say, let's do this in Ontario. Let's compare the models first. And if please don't think that I'm saying there aren't things we can learn from these other jurisdictions. But if you've got a green field and there's no installed technology base in your jurisdiction, and it's fairly large and it's comparable to this, that's not really that similar. That's a major difference from our Ontario ecosystem in health. We've got huge installed base, very political people who think their hospital information system that they just spent $60 million on is the best thing ever. And the fact that the hospital around the corner, they might just be across the street, thinks theirs is the best thing ever, and they're completely different from an architecture and a solution perspective. That's a major part of the problem we're dealing with. So let's not say, let's do what this group did. Let's watch what they did and learn from it, but let's apply it to our model. Let's look at governance as well. So HMOs in the United States is the perfect example where there's a very different governance model than we have. Doesn't mean they haven't done good things, and we learn a lot from HMOs in the United States. But if you want to be a doctor and you don't want to use the HMO system, you go and work somewhere else. We don't exactly have that same model, although there are some people I've talked to earlier today who've suggested maybe we implement part of that. And I think there are actually some levers we want to look at from an HMO perspective, and we certainly want to look at some of the things that they've done really well. And I will say, you can say whatever you want about their profit motive. There's a lot of good preventative care stuff and patient involvement coming out of the HMOs, some of them anyway. We want to learn about that. And the other thing is the health system model. Infoway, you can like them or hate them, but they're not a provincial government. Healthcare in Canada is a provincial responsibility for the most part. There's certainly lots of federal funding. So if someone was to say to you, Infoway is in charge of implementing electronic health records in Ontario, that's kind of something that just isn't going to work. They're going to play an important role as an accelerator of that, and we're working really hard with them on that partnership, but it's going to be very hard for them to be responsible for it. We'll see how that works out, and please don't interpret that as too negative a statement about Infoway. Now, here's a question. I'm not going to name the countries. We can talk about that again over a beverage at some point. But the world leader in EHR, just about everybody in the room can name the country that I'm talking about, 50% of the hospitals are paper-based. And almost all of the specialty care is delivered in the hospitals. Now, if we were here in Ontario, we'd be, hoisting ourselves on our own petard, and you have to be fairly old to get that expression used very often in your conversation. But we would say this is a failure. We've got 50% of our hospitals, a lot of our specialist care not included, and it's a world leader in EHR. And the reason it is because they've done fabulous things in areas where we're having a hard time. Primary care is a real problem for us, so I salute them. They're a leader in EHR and eHealth, but they're not perfect by a long shot. And I do know that I have sat again in front of groups like Treasury Board and been asked to deliver the perfect solution, and why can't you just do it like this other organization has done? It's a very different model, and we need to measure properly. And one of the things I started out many, many years ago, and drug systems was one of the first things I worked in. And I was trying to predict, one of the jobs I got to do was to predict how much the province of Ontario was going to spend on the Ontario Drug Benefit Program each year, because they want to know that right down to the penny as they get closer to the end of the year. And at that time, by the way, I think it was $100 million a year was being spent on drugs in Ontario. Well, I'm not sure how much it is now, but I know it starts with a B. It's in the billion range. So this is a big growth area. So we've got a lot of potential to work there. But we need to measure against reality and not marketing. All drugs, all people is something here in Ontario that we've been holding ourselves to a really high standard. My girlfriend is a nurse practitioner, works in Toronto with a lot of homeless and underhoused elderly people, lots of drug addiction issues as well, many of whom have not had a health card for a long time, don't have an interest in being identified either, and we're trying to come up with solutions to get them into our all drugs, all people model as we go forward. And we really want to do that, and there's some innovative things happening, but we're being told, well, you don't have an all drugs, all people solution until you fit that model. Here in Ontario, we've got a fabulous drug benefit program. It covers the seniors. Trillium Drugs program covers people who, have some challenges affording the drugs they need for the disease states that they have. We've got an excellent database for those that we expose in emergency rooms and other hospital settings. But it's not all drugs and all people, because the ODB formulary doesn't cover all the drugs that are out there. No jurisdiction's formulary covers all the drugs that are out there. And every jurisdiction out there has people who are not registered and yet are still using drugs. So, if you want to be theoretical about this, nobody has an all drugs, all people solution. All we have to make sure in Ontario is that we don't hold back growth and innovation in the drug field because we're trying to have a perfect all drugs, all people solution. Every province and territory has Aboriginal clients, don't always have a provincial identifier. They're marketing themselves as all drugs, all people, and good for them because they're moving the eHealth yardsticks forward doing that. So that's actually something from an EHR perspective. We actually need a little bit of marketing help as we go forward. And we had a Dominic Covey hooked in by phone not long ago, and one of the things he really talked about, I think that fits along where I'm going as well, is this isn't about the EHR. I really do think the EHR has to vanish, but it is about health system and pain and where we can work on some gain. And these are some of the problems in the healthcare system from my perspective. And it's a little bit informed because I did do a lot of the business requirements for eHealth in the late 20th century, I guess, starting in 1997. And at that time, there was some real pain in the system. And we looked at business requirements. We went around the province talking to people and providers, and very little government involvement, and said, where's the pain in the system that we might be able to help fix? Well, drug interactions and prescription challenges, I call them, we still have a major problem in that area. Drug interactions, the statistics, I'll get them wrong if I try and quote them, but researchers have convinced me when I've said prove it to me that in North America, drug interactions is in the top 10 list of causes of death. That's astounding when I hear that. And we have a huge problem in Ontario with people getting out of emergency rooms and into hospital beds when they need it because there are people in those beds who probably shouldn't be there anymore. And we're putting, I think, 400,000 people in the hospital in Ontario, or at least 400,000 events, because of drug interactions. We've got to be able to do something about that. I mean, if we move it from 400 to 300,000, that's a hell of an improvement right there. Let's do something about drugs. If we get an EHR out of it, that's a real bonus. Wait time management is actually something that has got a lot of political exposure. And we now report on wait times, or at least the Ministry of Health does, Ontario does, on the wait times for some key services. Cardiac, cancer, MRIs, I'll forget the whole long list. I think that's a fabulous step because we had, I don't know how many lists, every provider had their own list. I think most businesses got out of individual provider lists long ago, but we report on wait times. We don't actually manage wait times. And it is the first step. But people don't move from one wait list to another very often. And as I said, I am from the boonies of Northern Ontario, and my dad's up there, and my mother, and lots of relatives of mine. And so if you live in northeastern Ontario, you get services in Toronto, Sudbury, Ottawa. Those are kind of the three big areas where you're going to for some of the bigger challenges. Well, if your doctor regularly refers someone to Toronto, and there's a shorter waiting list in Ottawa, I'd like the system to manage that, or at least I'd like some management of that. And there's some interesting ingredients. The doctor in Haileybury is making his best efforts. The person who's getting the service is making their best efforts. I just think the system's letting them down a little bit. And, if there are techie people in the room or on the webcast, I think that's a fairly solvable systems problem. The technology is not the challenge there. It's a governance issue. But I really, I don't know. I would like to see that everybody in this room and on this webcast has access to the same services. That's one of the principles of the Canada Health Act. Part of that is wait times management. We've got a big role in eHealth. I think we can help that. Finding a primary care provider. I have this conversation once a month with smart people who live in big cities, are educated, probably middle-class income, and they can't find a primary care provider, and the system isn't doing enough to support it. And actually, the system's doing more all the time. And there are programs like Care Connects that the Ministry of Health have put in place that really show some movement in that area. That's very positive, but we got to go further. Every month, someone sits in my office or in a bar or a restaurant or at the curling club and says, I've been looking for a primary care provider for a year, and there's no system I can find that works. I've tried the college website, I've tried the phone, I've tried everything, and I can't find a primary care provider. And if that's a nurse practitioner or a physician or whatever, it doesn't matter. We've got a business problem that really bothers me, and you can tell I get really passionate about this. We've got to fix that. I think we can fix that. Moving from acute care to long-term care, there's lots of work underway to try and help this, but let's recognize the scale of this problem. And where you encounter this is when someone sees you and says, my grandmother had a stroke, she's in the hospital, she's had to have a hip replacement as well, she's lived in her apartment all her life, or at least the last 10 years of it, and I've got to find a long-term care bed for my grandmother. And if you're involved around the hospitals, they're doing their best to help you, and they're providing great care, and they're trying to do everything to facilitate it. There's still an inordinate amount of pressure on you to make your three choices and clear up that bed. I think there's lots of system opportunity to help that. eHealth can play a role in that. And I'll tell you, we don't need a complete electronic health record to do it either. And then the last one I put on this list, self-management of chronic disease. And people always jump on me right away. Self-management means you're doing it with your provider as a partner, but you've got a role in it. I know lots of smart people of lots of various income levels who can play an intelligent role in managing their chronic disease. High blood pressure, diabetes, you name it. We are information seekers and information users. eHealth has to enable that. Do we need a complete electronic health record for it? You're already getting the answer to that question. And I just want to go back as I close this section, and I'm going slower than I thought as well. This is why we've got the EHR. It's being created to facilitate that. So if it facilitates those things, we'll take the EHR and use it, and that'll be just fine. This is the kinds of things we want to use it for. I'll skip over this section fairly quickly. You've got it. We have. It's all about those piles of information. That's what it's almost all about. It doesn't mean it's a bad thing either. And by the way, the piles don't have to be provincial either. They can be local, and they can be regional, and they can have all kinds of difference. There can be disease state piles. We've got some good things in Ontario. Our provider and client registry systems, I'll hold up against any jurisdiction in the world. And in fact, it would be nice if we could get some other jurisdictions to use things like our health number registration system. That's some really good intellectual property that I think we can get some advantage out of. We've got all these others. OLIS is a perfect example. I just want to talk about it for 1 second. It has 220 million lab test results in there. It's not being exposed yet. That's the wave of the future. We've got to expose those lab test results. But one of the other themes is every test that ever went in there is still in there. So if you took someone's HbA1c in 2003 when OLIS started taking data in, it's still there. Is it part of your electronic health record? Well, if you follow the definition, it certainly is. Is it of any clinical use today? I don't think it is too much, but I'm not the person to tell you that. The clinical people have to. We've got to worry about issues like that as well. So the main message of this is we've got a lot in place. We've got to start taking better advantage of it. So we have a strategy. We've got an architecture, and people often forget that the architecture and the strategy go together. If they're not right, we're the people to change them. One of the most important elements of the strategy right now is a focus on diabetes. I don't care. Diabetes, I think it's really challenging that we have such an epidemic of diabetes in Canada and in Ontario. And I'll tell people quite honestly, the thing I like best about diabetes as a central focus of the strategy is it touches every person in this room. And it touches almost every primary care provider in the province of Ontario. And we need those people to get on board. You can modify the strategy, and that's one of the most important parts, is modifying the tactical elements as you go forward and validating the results. Are we getting the results we expected? If not, what changes are we going to make? It's got to be clinically driven. It has to be business aware. So business processes and a value proposition are there. It must be patient focused. And we've, as we develop it, because it was a government product for a while, tried to make it patient focused by consulting with patients and tried to make it provider focused by consulting with the broader health system. If it's not right, we're the people who can change it. We've got to move on some of it, though, and not wait for it to be a perfect strategy. And, of course, it's got to have an appropriate budget. But I will tell you, if you ask me to pick one aspect of eHealth anywhere and give it an F, a failing grade, I think we do a dramatically terrible job of estimating the costs of the projects that we're doing. There's built on some history and some estimates and some guesses on top of estimates. Well, let's improve that part of it as well and get better as we go along. I'll just bring this whole thing in. You can read this. These are, I would describe these as they're a little bit Doug Tessier's key themes. And I've got a fairly important role around some of this, but not the only role. We need to equip people. We need to support them. You know, if there are physicians in the room, there's been dollars to equip you for a long time from an eHealth perspective, not necessarily much support. So we've got to have all the elements. We've got to build some buckets that we don't have, and buckets is a very technical term. Let's put some information, let's get it electronic. Some of them are big and central, some of them are local and small. That's really important. And certainly government has tended over the past 15 years to try to make things big and central. And if you look around the world, just about everything is networked and local. Well, we've got to pull that together. There are some good reasons to have some things central, but let's find the appropriate solution. Then we have to expose those buckets. That's important. Start pushing that information out. I'm only going to pick a couple of things. It's a parallel process. It's not serial. We don't do diagnostic imaging and then do drugs. We've got to push some of those buttons at the same time because it is about the integration and the space in between. And we need multiple approaches. So, if the Northeast LHIN says we're going to do an e-prescribing implementation this way, and the Muskoka Simcoe LHIN says we're going to try a slightly different way, well, then we're going to evaluate that and see what works. And that's exactly what we did with those two small e-prescribing demonstration projects. We have to work smart as well as hard. Drug information systems and e-prescribing. Every prescription, this is always amazing because we're going to invest a lot of money to get a big drug information system for the province. Every prescription in the province of Ontario that's dispensed is recorded electronically today. And it's shared with someone. It might be shared with ODB, could be shared with a corporate head office, could be shared with a drug company, who knows what. Some of them are shared many places, private insurers. But we really need to ask ourselves, if it's all electronic now and it's all in a big repository somewhere, do we want to go back to the drawing board and start making it all electronic through a different channel? Those are the kinds of things we need to think about, and I don't know what the answer is to that. You need some smart people who understand the drug business to do that, but what we do next with that is the most important step. We've got huge assets from a drug perspective, and one of the things I point out on drugs, by the way, is I have one prescription right now, because I get a little dry elbow in the wintertime, and I get some cortisone cream, hydrocortisone for that. I'm not sure that's the most relevant thing to get into our drug system. I'm really glad that my family, where there are 8 or 9 drugs and lots of potential interactions, have theirs in the system. But if we go for all drugs, all people, we want me in there as well. And we want a lot of people in there who don't have any prescriptions. Let's figure out what our motivation is and what we're trying to achieve there. And those are interesting problems, I think, for us to worry about. This is just my problem. I'm venting again. eHealth project, not too much happens from a project perspective. that doesn't take 3 years to do. Now, maybe that's a challenge, and we need to shorten that life cycle a little bit. Right now it takes 2 years to get things approved. And, some of that is a function of the last year and some of the procurement rules that have come out of that, but not all of it. It's always been a real long cycle. Well, we've got a leadership cycle and an economic cycle that are shorter than that. And we certainly have a technology cycle that's much shorter than that. So we need to plan for the future. And that's a real challenge because, we've got lots of people who are really good at saying, here's what we need to do today. Well, if it's going to take 5 years to get through this, 2015 is light years away from a technology perspective. And we've got to do some things to bring some of those visionaries in. And I'll tell you, I worked for government for a long time. That's not where the visionaries usually are. So let's find where they are. And we're working at eHealth Ontario quite hard, in my area anyway, to make sure that we're starting to bring in some of those people. And being here today is one of those things as well. Really fast, provided I hit the mouse properly. Things aren't going forward. Let me try page down. Well, I'm going to let the technical people worry about that. I want to talk about some of the critical issues. Policy. Shirley can figure this out. She works for the University of Waterloo. Policy issues, major challenge. In Ontario, we have some policy barriers, and they're well identified and clearly understood. There are only 2 things we can't do with health information in Ontario. Integrate information from multiple sources and share it across the healthcare system with multiple users. Well, those are the 2 things we're trying to do. So we've got some policy enablers to put in place. The government is working on that. Places like the regulatory college is working on that as well. Let me just flip through this anyway, I probably unplugged it here, Shirley. So from a policy perspective, we've got to worry about that and get the regulatory groups involved. And that's the College of Physicians and Surgeons, College of Nurses. They're very ready to do this. I've worked with the regulatory colleges for probably 15 years of my career inside government. And I've also worked with the professional associations. You don't usually get that partnership, but it's an interesting partnership to be in. We need the regulators to come into the 21st century with us. We've worked really hard on that partnership, and they're ready for us. And a perfect example of that, I think, is around secure email. We've got healthcare providers of various types using email to send health information back and forth through Gmail and Yahoo and whatever, and it's not secured. And let me tell you, security is not the thing I worry about the most, but we're going to have a problem. When these things happen, they're used, rightly or wrongly, to slow the evolution of eHealth down. So we've got to get the regulators involved around standards of practice. If all they'll do is say, you shouldn't email personal health information to either a patient or to a provider without it being in a secure environment, very good. Thank you very much.
I'm not sure we can go forward with it.
Well, that's all right. I can talk about this slide for all the 2 minutes I've got left. So we've got to get some standards of practice. And the last thing we want, by the way, is for the College of Physicians and Surgeons to say, you should use this product. And there's a real tendency to do that. So we've got to educate those groups and move forward. Just say you've got to use secure email. And when someone says, what does that mean? Turn to the appropriate technical group, whether it's a standards body or it might be government in some cases. Here's what it means. Information and Privacy Commissioner. Ontario has the best Information and Privacy Commissioner in Canada. And my apologies to any rest of them. I don't even know them all anymore, although I used to. We've got a real asset. And the reason that I think Ann Kavukian in this office is a real asset, which goes along with, by the way, a very good piece of legislation, is that they understand what we're trying to achieve. And they want to do it in an environment of protecting people's privacy and, keeping in mind privacy from when you start. Because if you wait till the end of your process, you're in serious, serious trouble. But they're also really worried about how the healthcare system's performing. So when we took the baseline diabetes, which basically says 34% of the people with diabetes in Ontario are getting best practice care, and we talked to the Privacy Commissioner about that for about 10 minutes, we didn't talk about privacy once. We talked about the fact that physicians in Ontario have been saying we're doing best practice care, and the evidence only shows that 34% of the people are getting best practice care. So let's do something about that in an environment where we protect privacy, but let's solve the business problem. I'm not going to talk too much about the rest of it. These are some of the issues that we're doing with. We need to figure those out. There are people working very hard on them. But the key message is financial people are important, technology people, clinical, policy people as well as we move forward. Standards. I have, over the years, had standards reporting to me and done lots of pan-Canadian stuff on standards. I always have to have one slide. The standards project can't be bigger than the business project. That's one of the challenges that people have. I looked for a good picture on this. I couldn't quite find one. Imagine me standing here and I've got like 500 pounds of standards off this arm and 500 pounds of policy problems off this arm. I'm going to collapse on the floor pretty quickly. What we want to do is use standards properly. And if we can't take business problem A, pick e-referrals, and have message standards and data terminology standards, data content standards done in 6 months, the business has passed us by. Big change needed. Resources needed, academic programs needed to change and have some standards people here. Incentives and value proposition, it is about balance. Carrots, sticks. If you're a carrot person or a stick person, find someone who's the other kind and merge yourself, please. It's about balance. There's got to be some carrots and some sticks. Incentives have to be aligned, and we're starting to move along that path. The associations and the people who are being paid, I think are making good steps because they want to transform the health system and give better quality care as well. But we've got to have that in a balance. I'll talk about personal health records. They're not EHRs, right? If we apply our definition of EHR, personal health records usually maintained by an individual, and they're not usually integrated. This is one of the reasons why I think in the United States market, they're not really taking off. Because as soon as I put my 5 pieces of information in there, I want the 5 pieces of information someone else has in there as well. And there's value to both sides of that equation. I really think there is value to the 5 pieces I put in, but people are using them for a lot of different purposes as well. So if someone tries to tell you, we'll take Microsoft Health Vault or Google Health and we'll make that our EHR, go back to what an EHR is, but that doesn't mean we don't need those tools. Because the biggest thing for me, they really support portability. And we live in a portable world from an information perspective. There's probably more BlackBerries in the room or whatever product than there are people in the room. Because I know some of you business people have a personal one and a business one too. Information's portable. We've got to take advantage of that. A patient gets some control because there's information they put in there and they can decide who they want to show it to. And boy, it supports a role for an individual in their health care. And you can take away eHealth. And if you can get individuals to take more of an active role in their health care, we'll get more benefit out of that potentially. What we want to do is enable that with personal health records. Resource management, we need a lot more people. We need to keep the people we have. So I'm a little bit over time, but I just want to talk about the conclusions. So it's not about the electronic health record. That's been pretty clear. It's about what we do with that information. And that doesn't mean electronic health records aren't important. And we've got lots of political people measuring us by how many of them we have. That's life. Here in Ontario, we need to market that a lot better. Because I would say, if we were some other provinces, we'd already be saying we have an electronic health record. We'd take our ODB system and those drug profiles. And the DI repositories we have, all those people are in our client registry, and the providers are in our provider registry. In a lot of jurisdictions, that's an EHR. I don't think it matters. We've got to build those things and get the clinical use out of them to enable system transformation. So we've got a good strategy. We've got a good blueprint. Doesn't mean they're not going to change. We're going to use them to move forward now, and we're going to have to get some advice from some expert people about changing them and evolving them. In order to do that, you need outcomes, and you need research and results and evaluation of those things. Key, though, this last point I talked about before. If we are taking a 2010 solution and planning for it to be a world leader in 2018, I really think there's a fundamental flaw in that logic. So how we do that is going to be an interesting problem. We've got lots of smart people here in Ontario and in other jurisdictions to ask that question. Value proposition has to be clear. We need to do a lot better job. So for any of the bean counters in the audience who thought I was ignoring you, you're important too. And we've got to look at it, because I think, as I was saying today, we got a big problem worldwide in developed countries, and we've got lots of problems in countries that aren't developed too. But we're starting to take money out of housing and education and put it into health. And, someone told me, a very smart researcher sometime or academic, that housing and education are two of the most important determinants of health. So that would be described as shooting yourself in the foot in some of the groups that I hang around with. So we really need to remember why we're doing it. EHR, we don't always get to prove how we're going to be measured and how success is going to be measured. We'll move down that path. I think it's a lot more about using health information and sharing it appropriately to achieve some clinical outcomes. And that's about enabling some health system sustainability, because we can't afford the path we're on. It's about integration, which is something we do really poorly. And someone I have a great deal of respect for, Duncan Sinclair, when he was driving the Health Systems Restructuring Commission, and I think he was a couple floors above us in the building in Toronto, and we rode back and forth on the train a few times as well to Kingston, where I think he lived and I now pretend I live. One of his themes was integration. It's pretty simple. It doesn't take you very long to figure out we need an integrated ecosystem here. If you think you can do that without information flowing across the different silos, well, good luck to you, but I wouldn't invest too much money in that model because I don't think it's going to work. We're going to have to integrate the information if we want to integrate care. It's about quality care and patient safety. That's a pretty simple message, and I'm sure people would tell me it may be a little bit naive, but I believe it. If we can improve quality of care and patient safety and always give the test to every eHealth investment we make, then we'll figure out if an EHR is going to help us. And somewhere along that path, we'll decide we have an EHR and we'll have a big celebration and announcement, and then hopefully we'll forget all about it. In 2020, hopefully nobody in Ontario is saying, I've got an EHR and it really enables it. But I hope they're saying, I've got really good quality of care, I feel safe when I'm encountering the healthcare system. As I move across the various parts of the system, the information that my providers need to do a good job of taking care of me and to help me prevent problems in the future is where I need it. So, thank you.
Well, that was a great presentation, and I know that probably there are a number of questions out in the audience, but maybe I could just take a moment and recap some of the key messages that I think at least I heard, and that is that really one of the issues related to the EHR is that it doesn't really represent the proper focus of eHealth, and that really the focus needs to be on matters that are the challenges to our health system that we need to address. One aspect of the Ontario strategy that is satisfying, that is being targeted, is around diabetes. But perhaps it doesn't need to be a centralized solution, and you talked a little bit about that as well. But how do we handle, or where do we have centralized solutions versus localized solutions? I still seem to be getting a hum here. Am I in the right location? Better? So perhaps you can just clarify a few things. When do we use a centralized solution? When would it be best to address the different types of patients with their many different needs and motivation, as in diabetes? When would a single solution be more appropriate but we need to use perhaps these single solutions because they represent local innovation. So perhaps you could just address some of these things that I've just mentioned.
Yeah, I can try, and I think I touched on this a little bit, and I actually think it's really hard to say where a central solution is better than a distributed one, and you kind of have to look at your business model and follow that. We've got a central solution on diabetes, I think, because it's a large political agenda, and it's a province-wide and worldwide problem. And the first couple steps, the diabetes registry, is going to be developed centrally and distributed through a portal to lots of potential places. And one of the things we have talked about is, I just love portals. They're a really neat solution now. Some of you people who have less gray hair than I have can tell me what the neat solution will be in 5 years, and I'll listen to you. But one of the things about these solutions is people have delivery channels that they like. And we've got to follow the channels that they like. So if there's not an established delivery channel, then you might do something centrally. Possibly anyway. But if there are established regional or local delivery channels, then that's a good sign to me that there's lots of potential for regional and local solutions. And one of the things that's interesting in Ontario is we all compete. Hospitals, I guess that's true everywhere, but I feel it more here in Ontario. Hospitals, LHINs, primary care groups, whatever you want to call it, we're trying to come up with the best solution. And one of the things I like about the portal approach, I always mention the BMI calculator, and I guess I'm giving away one of my challenges in life that I'm always looking at those. But if someone wants to develop a new one, they develop a little applet or a portlet or whatever the heck you want to call it, and they put it up there. And the people decide, does this work or doesn't it work? Am I going to replace my old one with this one, or does this one work just fine for me? And I think we're really getting a lot more into that environment. We are getting into portal approach. We're getting into smaller applications instead of some of these big central ones. We've got central ones already for labs, for client registry and provider registry, and I think there's some good ideas around having those central, but a lot of this is going to be driven by what people want. And innovation is not very often a big centralized function. Well, one of my themes of eHealth, we need innovative solutions, so I think there's a lot more room for regional and local solutions, but I will say, one of the things we do want to avoid is every LHIN. There's 14 of them. If they all decide we want to develop our own diabetes solution, that's probably not a good idea. But it doesn't happen either. The LHINs already have natural partners. Erie, St. Clair, and Southwest don't very often do something independently because there's lots of natural synergy. Northeast and Northwest, from a resource perspective, are just like this. They've got individual characteristics. They're very different. As someone from Northeastern Ontario would tell you, we're way different than Northwestern Ontario, but there's some natural synergy. So I think we're going to get some of that. We're going to have to evolve this as we move forward and find where those solutions fit and where they work.
Do you see a way that we can facilitate and fund some of these grassroots efforts that would provide local innovation at that level?
I think for sure we can. And I do know, I've been to the eHealth Ontario board and to government probably 15 times over the course of the fall for various approvals, most of which have been for at least regional funding and a lot of local funding. So e-prescribing demonstration projects, because I'm not from Toronto either, although I spend a lot of time there now, it's not all about the corridor within 100 miles of Highway 401. So e-prescribing demonstration projects, which are really successful, lots of evaluation to show that as well, are in Collingwood and Sault Ste. Marie. We've got regional projects, and I call them regional because they're distributed that way. They're often quite small. They're a local group with 10 or 15 providers involved. Lots of room for those to go because it's not one big play. If you hear there's a couple $2 billion for eHealth, that's not one bucket. There are a lot of little buckets, and they're going to be distributed. I think there's lots of room for that. And a lot of it is driven by the priorities that happen locally and regionally. And let's face it, our politicians are elected locally and regional, so you can put pressure on lots of different ways.
And I guess just to finish off this discussion, and then we'll go to the audience, going back to the discussion about diabetes, the real challenge is not really managing patients with diabetes, but rather preventing diabetes, or at least slowing down its progression on a significant number of people. So this is the root cause of the problem that must be addressed by nutrition and fitness management. So how do we get this done?
It's a perfect question because we've all got to work this one out together. Everybody in the room knows a diabetic. There may be some in the room, and there are those issues. So we're focusing with diabetes, and we're taking some small steps centrally. And, the nice part about diabetes, by the way, is nobody at eHealth Ontario decided what we were going to do. A diabetes expert panel with clinicians, lots of patient input to it as well, said this is what needs to happen from a diabetes perspective, and here are the indicators you need to track. And by the way, if you put a whole bunch of clinical people, at times there were 75 people in the room, there's lots of discussion about what are the right indicators. Well, we've got a diabetes registry application. We're going to expose through a portal and through people's systems integrated into EMRs and hospital systems that looks at 3 of those indicators. That's the start. Because if we don't get to patients, people, now let's face it, they're people and their families having an interaction, taking an interest, using something like a personal health record, that's a big part of diabetes because it actually starts, there is a component of that where people put their own information into the diabetes registry. Is it a perfect solution? I don't think there are perfect solutions. We really need to get people saying, I'm going to take some accountability for my own information. I'm going to play an active role with my provider and move forward. I think that's the future as far as I'm concerned. And I said as well when we had lunch earlier today, When I started with the Ministry of Health many, many years ago, I'm sure one of the first presentations I heard, I can't remember who it was from, some sage person who came from Toronto down to Kingston, was very wise and said, the name of the game is health promotion, disease prevention. It is quality of care and patient safety, but we've got to get to where we're dealing with health promotion. It's about health, not just about health care. Well, that message has been delivered in many, many forms every year since that year, and I'm not sure we're there yet, but I think eHealth can really enable people starting to move down that path. And let's face it, we've got to follow what people are doing. Information's portable. People want to have access to their own information. We're going to have to enable some of that, because one thing's for sure, they're not going to take it very far if they don't have access to that information.
So I think there's a question in the audience.
Thank you very much. Thanks, Doug. Good presentation. Erie St. Clair Land is where I work. Our grad student from MAC produced a little passport on diabetes for Sarnia Lambton, because of the diabetes patients, people with diabetes in Sarnia Lambton, 85% of the care is given there. So she gives a little passport. We put on our web and say, this is how you find services. Little simple, integrated thing.
For sure.
The main question I have, though, is on what I think is an inconsistency or a LEND. 14 LENDs have 4 product lines. Remove your gridlock in the hospital. Reduce your ED visits, because half the people shouldn't be there. The third one is improved diabetes services. Yeah. And the fourth is improved mental health. 4 product lines. If a business was to put down where its profit and loss is, it would put out its costs related to those 4 product lines. Mm-hmm. So when we got $125,000 last year for our LEND, and then it went up to $600,000 this year, plus diabetes put a little bit of money in, et cetera, we're getting, if you project it, you're going to be into a few $1 million for our eHealth in Erie St. Clair. Mm-hmm. And similar to other LENDs, we don't take that $600,000 or $1 million, $3 million, and start to tie it in with our priorities and say, this is where we invested, this is what we got. Because eHealth is supposed to be an enabler. So how did it enable the reduction of your ALCs, your gridlock, reduce your ED visits? Because if you don't tie that together, I'm afraid in about 3 years we're going to have another eHealth mess. It's going to be in Muskoka, say, northeast, northwest, and 14 places in Ontario.
Yeah. I mean, if you'd asked that before my presentation, I could have saved some time, because I think there's a lot of themes in there that are really important. And by the way, the local innovation that you talked about, that sounds like a good thing to me. It would be nice to not have that reinvented in 13 other places. So hopefully we can enable that. We can put that on. We can at least tell you what it needs to do to be on a portal that can be shared, and on lots of different portals. But I think, you talk about those 4 priorities. The challenge is, I think there are a lot more priorities. Those are the 4 stated ones, but they're not independent either. And, I'm a little bit of a technology guy who spent a lot of time around the health system, but, you want to deal with ALC days, you better deal with diabetes, because that's why you got a lot of people coming in there. You want to deal with ALC days, we talked about the drug interaction challenge, and we did have a conversation about how this is a real networked ecosystem. There are really complex problems, as Dominic Covey calls them, wicked problems. And we're not going to solve them overnight. We've got to start working on them. And one of the things you talked about, though, as well, was we don't know why things happen. So we did this, and we're not sure if it had that result. That's one of the big themes. If we're going to take some action, one, let's hope that all the 14 LENDs don't take the same actions, right? Because then if we make a bad choice, we'll all make the bad choice. Let's get some different things. Let's get some people involved evaluating those. And, if that's kind of a non-answer, maybe it's because I'm, with eHealth Ontario, and it's about the whole health system. LENDs, by the way, they're one of the most important partners we have. That's not to diminish the other partners. So we've got to deal with some of those local problems, deal with some of those solutions, see what the impact was. Because part of the challenge, I don't want to get too much into the relationship between the LENDs and hospitals, but it's a little bit of an immature governance model. And somebody's going to have to figure some of that out. And I want to stay out of that political bit, because even though I don't work for the Ministry of Health, I'll say something critical and I'll hear about it from someone on the webcast. So.
There's a question over here.
Hi. I heard a presentation, I guess it was last week, by a guy named Andrew Wiesenthal, who introduced the EHR system for Kaiser Permanente in the U.S., which is a health management organization that is roughly equivalent to Ontario, slightly smaller, about 8.7 million patients, 14,000 physicians, 165,000 staff members. 5 years ago, they adopted a platform, introduced it, and he presented in Toronto last week and spent, I don't know if you heard the presentation, he spent about an hour boasting about the incredible achievements, cost savings. And the one thing that he really, really hammered away on was patient satisfaction. And he really, really struggled to pass on the message to this Ontario audience that the way you get people to use the system and to actually drive down costs of delivering health care for the provider, which is you, is by getting patients online every day, putting in their blood pressure information, self-management. That's where the cost savings is. In your own presentation, I heard almost nothing about that. Can you talk a little bit about that?
Sure. I think that's a very valid point. One of the things you have to be aware of, though, is you've got lots of HMOs in the States implementing systems like that, and they do a good job of marketing. And by the way, Kaiser's fabulous with what they've achieved. Patient satisfaction is one measure. There are a lot of other measures. But I think, I would actually agree with you, and I actually thought I covered that. I clearly didn't emphasize it enough. Patient involvement in accessing their own health information, that's one of those principles that you've got to establish right away. Involvement in self-management, partnered with a provider, entering their, like in the diabetes registry, they're going to have an opportunity to put in their blood sugar readings, to put in their blood pressure, hopefully. That'll be one of the indicators we'll move to put in an exercise log. Those are the kinds of things that we're moving to because the system's not changing. Like if we keep doing the stuff we're doing right now, we're not transforming the system. So my theory certainly is that much more patient involvement, and by the way, when I say patient, that means patients and their families. Because quite often the patient isn't the person who's going to really care about their exercise that day. It's somebody in their family, and that's a small f family. It's a person of interest. I think that's one of the real potential transformational elements, and it's something that we have a challenge with. Part of the challenge is getting the input from the right group of people and starting small. Because we've got 13 million people almost in Ontario. We can't get them all access to their personal health information right away. We've got to start small with things like diabetes, move forward on that. I think drug profiles got a lot of potential because there are really lots of people, I think, who would like to have their parents' drug profile so that when they talk to a provider about it, they really know what's going on. So huge potential. It's got to be an area we can tap. And I really think we need some of the academic groups and the researchers to help us with that, to look at what's really worked. And, nothing against Kaiser. Great organization, great marketing department. So, that's one of the things we have to watch and make sure we're marketing as well, and we want truth in marketing. So,
there's a question here.
Thank you very much for your presentation. I got involved in electronic health, or just got curious about 10 years ago, and my very first presentation that I went to was by Dr. Alex Haddad in Toronto. Yeah. And at that time, the whole eHealth thing was still in its very infancy in terms of how to move forward. And one thing that I guess I struggle with is the key message that I got from your presentation was integration of information between various organizations or between various data storehouses, if I can use that term.
Buckets.
Buckets, exactly, the technical term. I'm a bit surprised because when it comes to gathering electronic information, information integration and exchange is almost something that goes goes together. It's never one or the other, right? Mm-hmm. So how come? And that was the message I got 10 years ago at that presentation, that the integration is the key. So how come it's taken us 10 years since then, and we're still asking the same question? How come we haven't moved forward on that? Yeah. And then the second question I have is about second-generation applications. Once you have these buckets and once they start talking to each other, what are some of the second-generation, for example, distributed applications that provide maybe a physician and two physicians to collaborate and work together, like those kind of things that might be coming down the pipe?
For sure. So, you have a lot less gray hair than I do, so you can help me answer that last question. But on the integration, why we're talking about it is because we're still not integrated. We've made steps down that path, and we've talked about integration, and we've really worked hard on those buckets. And most of the buckets still don't connect. And some of that's an incentive model. Some of it is, programmatic change. Why did the government, where I worked, decide that we were going to attach physician funding for eHealth to primary care reform? Well, primary care reform was a big driver, and we really did need primary care reform. We needed care to be done in a different way and a different model, and we're along that path. And researchers will tell us how that path has gone, but it wasn't an integration play. And I think as well there's a little bit, I don't want to describe it as a political, but it is that governance issue. So within silos, governors are really good at spending the money that they've got now and not giving it up and asking for more. And that's a positive. I mean that in the most positive light. I think back, though, the drug profile viewer, I talked about it a little bit. And we've got our ODB data, and we expose it in emergency rooms. And when we did go around the province looking at all those pain areas, the bag o' drugs was one of the most amazing things I ever saw. It's someone comes in and here's a person and they're sick and I'm not really sure what's wrong with them, and here's all the drugs they're on. And they dump it out on the table. Pink, yellow, green bottles, some without labels. You open a bottle and there's like a yellow one and a green one, and who knows what it is. Well, it must now be about 8 years ago, there used to be a group called the Ontario eHealth Council. And I remember that at that time the CEO of the Medical Association was on it. Tom Clausen was on there representing hospitals, and Camille Orridge from the Toronto CCAC represented the community. And those three people got together and said, from a health system perspective, and there were other people on the group, I was a member of that council, Laurel Taylor, various other people, and said, from a health system perspective, is there any low-hanging fruit? Like, is there something we can do that's an integration play, a little bit, that helps? And they said in like 20 minutes, it's that drug profile viewer. We've got to take that drug information and expose it. The techies in the room will tell you that's not a very hard technical problem. It was a hard political problem and a hard governance problem, but we managed to do it, and it provides value. We've got lots of feedback from providers that when someone comes in the emergency room, I've got their ODB information right off the top. Huge patient safety and quality of care issue. That's one of the first little bits of integration across the system, and you had three visionary thought leaders there, or to some extent anyway, three people I certainly respect a fair amount, saying it's not about hospitals, it's about sharing that information, and it's a little bit of an integrated view, and there's a value proposition for it. But almost all of the value proposition is siloed. So if we're trying to encourage integration, it's really hard to do that with a value proposition that's vertical. So we've got to move towards that integration play and get the value proposition to match that. Second generation applications, the next thing we do, I hope it's going to be pretty organic. And one of the stories I like to tell, because I have dealt with providers a lot over the years, this is one of my favorite stories. I've got many stories. Specialists and primary care physicians. I facilitated a group, and I think the topic was standards. I don't remember exactly what it was, with about 6 primary care providers and 6 specialists of different types in a room. The specialists sat there and said, I spend 30% of my time every day seeing your patients, and I don't have the information that I need to take proper care of them. I've got to go and get it again. That's 30% of my time. And the family physician said, I spend 30% of my time trying to find out what the heck you did with my patients when I referred them to you. Okay, there's a grade 8 class out there somewhere who would look at this business problem and say, we can solve that with a little application which says, here's a standard cardiology referral. Let's decide what it is, and we'll send it back and forth. And here's a standard cardiology report. It's getting there. It's going to get there locally, too. And if somebody's got one of those and we can work out a way to share that through a portal application, let's do it. But it's going to be organic like that. And hopefully the light bulb will click on and some of those groups will say, I've got an answer. And by the way, when we do things with the regulatory colleges, it's a really interesting group. Dentists have some innovative ideas. We got to find some groups who aren't necessarily our traditional groups. And that doesn't mean it has to be in healthcare either. Maybe I was going to say Ontario Lottery and Gaming, but we don't like to put eHealth and Ontario Lottery and Gaming in the same presentation. But we got to look at other businesses because I go at that effect about the financial industry a little bit to prove a point. But they've done some really good things because by gosh, cash withdrawal at a point of purchase works perfectly. And we use it more than we use just about anything in Canada. So let's learn from some of those other industries too.
I'd like to take 2 more questions. So one from the audience and one from the web. Say right here.
Thank you, Doug. That was a great presentation.
Thank you.
My name is Severio Rinaldi, and we presented to you about the Clarity Health Journal, the personal health record. And I wanted to come back to your exact point about the financial institutions. As a co-op student from Waterloo, we worked with a trust company rolling out the first type of cash machines, the Johnny Cash machine, as it was. And it has come a long way. Integration in the financial sector. As a small business owner, I download my transactions from my banks, multiple banks, do payments online, do a lot of the integrated work that I would expect to financial institution to do for me.
Right.
When it comes to healthcare, and we've all talked about it, there's a lot more that can be done. I'll bring it back to the basics. The very first thing, when you go in and you have two types of health card numbers in the province, you have a red and white card that it doesn't uniquely identify an individual. You have the new health cards with version codes. And obviously, as a universal healthcare provider, we have patients from other provinces who come and go. So I would contest the 94%, patient registry, the EMPI that uniquely identifies patients isn't actually there. It's a part way there. It's a solution that, as we move forward, has to be revamped. When we revamped our driver's licenses, it was done in very quick order. I'm looking back at the healthcare system, and we're still using embossed cards. You go into a hospital, you're still using an embossed cards. We're talking about the credit cards that were issued in the 80s that are embossed. Can we do something about uniquely identifying patients, issuing patients with unique identifier cards that have critical information, whether it's drugs, whether it's allergies, so that a patient coming into a merge, coming into a practice, can be seen and the right information is there immediately without having to worry about all the other problems.
So I think we could have a long conversation about the client registry and the red and white cards. And by the way, I was the auditor on the conversion from OHIP cards to red and white cards. And I left that job. One of the reasons was because there should have been a signature on that card and some other identity. And let's not go too far down that path. And that is, there are some Ministry of Health issues there. And I'd like to make policy for the Ministry of Health, but they don't let me do that too much anymore. We want to get people to a photo health card. That's a big part of this, right? Because in personal health information, if we're going to share it and we're going to access it in multiple locations, we gosh darn well better know who we're dealing with. So we certainly want to move to that. And the fact that there are still embossed cards around, that's a big challenge, right? Anytime you've got multiple identities, and I will say though, I've had many, many conversations about whether we want a health number or we want an EMPI. So if you're out there and you actually study client registry, you need strong, unique identifiers, and you need an identity resolution tool. The two things work together. We've got them in pretty good shape. And by the way, fair game, it's not a perfect solution, but from an identity perspective, a health number is one of the most reliable, unique identifiers in use, an Ontario health number, in use anywhere in the world. Anywhere in the world. And when people come in here, we've got capacity to put 10 billion people in there if we need to. And we've got approval up to the cabinet level to use that as a unique identifier for health. But it is a policy issue because there's some legislation that needs to change it. Sooner we do that, the better. Red and white cards, this is an interesting business problem because there are people in the room with red and white cards who love having a red and white card. And your provider loves it if you've got one too, because it doesn't have a version code, it doesn't expire. And I actually made the decision, my red and white card cracked, and I said, okay, I'm going to go and get a health card with a photo on it and a signature and all that. It was a real pain in the ass for a while. But I'm used to it now, and I understand why we need to have it. So we want to move those things together. And, let's face it, we have got distributed registration systems. We've got address that needs to be improved if we decide that that's important. But one of the things, take driver's license. There's not a lot of legislation that controls what you can do with that number. If you want to use it to get into as your identity to buy alcohol, That's fine. It's a valid photo ID. You're not supposed to use your health card for that. Certainly people aren't supposed to ask you for it to use that. So there's a legislative and policy framework that the ministry has to help us deal with around that. But, we've got to get down that path because we've got some strong assets, but they're not perfect assets. We need to do some things to take them a little bit farther along that spectrum, for sure.
I'd really like to get one question from the web.
The question from the web is a two-part. Are you going to provide an EMR solution for medical institutions, or are you going to provide an interface so that EMR companies can obtain data from EHRs? And also with this, how will you upload all the data from the different clinics?
So that's 14 questions, and I'm very glad to have it because EMRs, I think one of the things that comes through in that question for me is that you can define institutions and EMRs and information a lot of different ways. It is about integrating information. So you've got to have a vehicle, no matter what the source is. If it's a physician EMR or a hospital information system or a personal health record, you have to have a way to pull that information together. And that works with consistent architecture, standards, and a messaging framework. And one of the messages I always like to deliver is there are people out there who love interfaces. So we'll take this person's system and this person's systems and we'll build an interface between the middle. I'm not sure I remember a lot of the math that I did in university at Queen's, some of it, but if you take that, it becomes an exponential problem really quickly. So we have to do things from a standards perspective, and in EMRs, for example, there's a specification for physician EMRs. We get lots of value out of those physician EMRs, but when you talk about institutions, by the way, community health centers, which are very important from a healthcare perspective, and if diabetes is going to be our focus, they do a lot of diabetes care, they have a different system. They all use the same system, they all use it in different ways. It doesn't match the specification for physician EMRs. I think we need to do that, make sure that it covers physicians, nurse practitioners, dietitians, whoever's working in those areas, and get the information. So, the answer to that is, if you're playing in the healthcare system, then you're generating information. If we want to share it, we need a vehicle to do that. It doesn't necessarily mean we're going to supply people with software and hardware, but there's some information we're going to share. We need some vehicle to do that.
Well, I know that some of you didn't have the opportunity to ask your question, so please stay and perhaps you can ask it in person to Doug. I just want to close with something that's near to our hearts, and of course that's education. And we see that our students are critical to the formation and creation of eHealth teams. And how do we get better funding to support the education for these students that we need? How and when will these funds flow? Because right now it seems to be a bit of a bottleneck.
That is a really good question, and I'll try to be politically astute. There are lots of different places. If this is a priority in Canada, then we want lots of people with money to get behind it, and government is one of those, and making a significant investment. And this, I think, has taken some real political guts to say we're going to continue this. And as I said with John F. Kennedy, it's going to take some political guts to stay on this bandwagon and move forward, which means everybody here has got to speak to our politicians and say this is important. I think private industry has a huge role to play in that as well if there's a value proposition for them. And I talk about the value proposition. Well, there's not one. There's multiple. It depends where you are. We all measure value differently. But there's a huge opportunity. Let's face it, if we say personal records and mobility are important, we're not very far from some people who really do a good job on that mobility front. There may be an economic model for them, and then I think we've got to encourage investment that drives forward some of the programs. And one of the things I would say as well, by the way, we need all kinds of different people. It's not all about health informatics. I basically was a mathematical modeler and a technical person who got into this. And I do actually have a connection with the University of Waterloo, other than the fact that many of my friends went here. I think Waterloo used to publish a journal many years ago called the Canadian Computer Education Journal. And that used to go around to various universities and publish innovative programming approaches and programs from university students across Canada. And when I was in grade 12, I had a program published in that Canadian Computer Education Journal. But that was about 1970, a long time ago. I was very proud of that, and it was actually around sports simulations. And for some of the older people in the room, or people who remember this, that's batch processing. It's punch cards and Fortran and 2 boxes of cards. And I actually was quite proud of that program, was pleased to have it published by that journal at that time, and it was published by the University of Waterloo. And I didn't go to Waterloo, and my kids also would say to me, or at least some younger people would say, if you were doing innovative sports simulation programming in 1975, why aren't you really rich? You really made some bad steps and you've gone the wrong directions, and you really should have turned that into something. Maybe it's because I went to Queen's, I don't know. But somewhere along the path, eHealth got in the way, and I am really passionate about eHealth. We can transform the health system. We don't need a big EHR to do it, and we don't need the whole thing at once. But some of those business problems and those pains, we can fix. And we can fix it fairly shortly, and you don't need the government or eHealth Ontario to do it either. We can work together on it. So I feel passionately about that. I hope that came across. I want to thank you for the opportunity for having me here and for the audience as well. I've had a blast.
I'd like to thank you, in addition, with this small token of our appreciation.
Thank you
so
very
thank you for being here. And as I mentioned, we have a number of our students here from the UWIC club, our Health Informatics club. I invite all of you to stay and mix and mingle for a little bit. I think we have the room for our next at least half an hour or so. So please stay and have some invigorating conversation. And thank you for coming today. I look forward to seeing you again in March. So thank you.